So this video is part of a remote learning chronicle through Aurora University, and I'm going to be doing a thorough analysis of the DSM-5, and I'm going to go through the entire book, and we're going to discuss some of the diagnosis in the DSM-5, some of the history affiliated with the book, along with other components that are found in the DSM-5. So let me go ahead and start by saying that the DSM-5 is an abbreviation for the Diagnostic and Statistical Manual of Mental Disorders, the fifth edition. And these collections, these manuscripts, date all the way back to about 1952, when the first DSM was developed. And this was in conjunction with the ICD-6, the International Classification of Diseases, which is created by the World Health Organization. So these DSM manuscripts have been root all the way back to the 20th century. And so currently we are on the fifth edition, but there's a wide variety of texts pertaining to how to effectively diagnose and how to efficiently understand mental health disorders. That is definitely worth reading and analyzing. And so let's get started. So the DSM-5 is a manuscript that was created by the American Psychiatric Association in 2013. And it's very important to understand the structure of the American Psychiatric Association, along with some of the authors of the book itself. So actually, when writing the DSM-5, you have a series of medical doctors that get together through conferences, through meetings, to sort of discuss whether there are going to be enhancements or improvements from previous DSM-5 manuscripts. As of current, there are a wide variety of officers and doctors that sit on the board of the American Psychiatric Association, who discuss what types of changes should be made to the Diagnostic and Statistical Manual. So from 2012 to 2013, when the DSM-5 was being conceptualized, you had President Dilip V. Justy. He's a medical doctor, and he's actually a geriatric neuropsychiatrist who specializes in treating schizophrenia and psychotic disorders. So that was the president of the sort of the officers that create the DSM-5 at the time in 2013. I believe that he is still the acting president for the time being. And when trying to understand the essence of the DSM-5, it's very important to understand who wrote it and who was involved in the committees that ultimately put together this manuscript. So Dilip actually has written two books. The first book that he wrote is called Wiser, The Scientific Roots of Wisdom, Compassion, and What Makes Us Good. So that was his first book. And then he also wrote another book called Understanding and Treating Tardive Dyskinesia. His background in medicine is primarily dealing with individuals that have schizophrenia and psychotic disorders. And that you can really see that in the DSM-5 because it really does influence the sort of the diagnosing criteria, along with some of the symptoms that are required to meet a comprehensive diagnosis of schizophrenia. The president-elect of the officers of the DSM-5 is Jeffrey Lieberman. He's a medical doctor as well, and he also specializes in treating schizophrenia and psychosis. And then, the way it's structured, you also have a treasurer, and then you have a secretary. So the treasurer is David Fassler. He's a medical doctor. He specializes in child and adolescent psychiatry. And then the secretary is Roger Peely, and he specializes in addiction medicine and psychiatry. So those are the sort of the leaders of the DSM-5, the sort of the officers that lead the charge towards creating and revising and putting together the DSM-5. Um, so um, so let me go ahead and move on by talking about the general purpose of the DSM-5. It's very important for all disciplines of medicine to have a book that everyone can use to sort of agree upon what the symptoms of a particular disorder are, and to kind of have a general consensus as to what contributes towards the development of certain mental illnesses. The purpose of the DSM-5 is to have individuals from different professions come in agreement with regards to what the clinical definitions and the clinical requirements for certain disorders are. This includes the field of psychiatrists. It includes physicians, psychologists, social workers, nurses, counselors, even individuals in the field of forensic specialties, legal specialties, along with other mental health professionals. The DSM-5 allows all of those professions to come together and agree upon the different symptom criterion for mental illnesses. It's important to add that the DSM, all the versions of the Diagnostic and Statistical Manual, are always in harmony with the International Classification of Disorders. And I did talk about how the first DSM that was created in 1952 was in harmony with the ICD-6. Well, you do see that the DSM-5 is in total harmony with the ICD-10 classification of mental health disorders. So when discussing the DSM-5, I think it's very important to talk about some of the enhancements that have been made from previous diagnostic and statistical manuals. So let's talk about the enhancements, because there have been several enhancements from not just the DSM-4, but even from the DSM-5. The DSM-3 rather. So in the DSM-5, you do see that there is this representation of developmental issues related to diagnosis. What that means is that we have to be very careful when we are diagnosing children, adolescents, and adults with certain types of disorders, because the symptoms don't always look alike. So, for example, a child that is demonstrating symptoms of PTSD has a different way of revealing those symptoms contrary to how an adolescent would demonstrate those symptoms and how an adult would reveal such symptoms. And this doesn't just pertain to PTSD. This can also include anxiety, stress, and even intellectual disabilities are exhibited in different types of fashions and manners by individuals that are of a different age. And this philosophy, I think, is very pertinent to neurodevelopmental disorders in particular, because you do see a very distinct, different presentation of these symptoms among the different age groups that I had just mentioned previously. So that's the first real enhancement that the DSM-5 incorporated in comparison to its predecessors. You also have this integration of scientific findings from the latest research in genetics and neuroimaging. So the DSM-5 really brings to life and really embraces this idea of technology, using technology to better understand different mental illnesses. Now, this neurocognitive domain, or this neuroimaging criteria, doesn't necessarily apply to social workers and licensed clinical counselors, but this is very relevant to physicians, psychiatrists, and even psychologists. So it's important to place a limitation on that criteria, because nurses, social workers, counselors, they don't deal with neuroimaging, and they don't necessarily deal with neurocognitive complications when it comes to treating clients. But So you do have this, this incorporation of the latest genetic and neuroimaging findings, and this is really important when it comes to understanding some of the genetic factors that might be contributing to a particular illness, especially when we're talking about spectrum disorders such as autism, and even substance use disorder. It's very important to understand whether the individual has inherited certain traits from family members, or if the client's father or mother or siblings has a predilection towards using substances that may potentially be a genetic precursor towards that individual having a certain adherence towards a substance disorder. So that is the sort of the second enhancement that was made, and there's additional enhancements that the DSM has incorporated, particularly this idea of consolidating autistic disorder with Asperger disorder and other pervasive developmental disorders into the cluster of autism spectrum disorder. So this means that Asperger syndrome has been eliminated from the diagnostic and statistical manual, and it has been incorporated into the criteria of autism spectrum disorder. And the primary reason this occurred is because when you look at the definition of Asperger syndrome, and when you look at some of the symptom criterion for Asperger syndrome, you do see that it's a developmental disorder that affects the ability of an individual to effectively socialize and communicate with others, but that an individual that would have been diagnosed with Asperger syndrome would have been considered to have a higher functioning version of autism spectrum disorder. And so the two diagnoses are very much so related. They're very similar. And so it made more sense to simply say that Asperger's syndrome is a higher functioning type of autism syndrome. And so it's much more convenient to place it under the lower spectrum criteria of autism spectrum disorder. So you do have that elimination of Asperger's syndrome consolidated into autism spectrum disorder. Another enhancement is this philosophy of streamlining the classification of bipolar 1 and 2 disorders and also depressive disorders. And so this goes to say that bipolar 1 and 2 both have this manic and hypomanic component to them, but that they also have a major depressive component as well. And then realizing that major depressive disorders as well have the ability to have manic and hypomanic along with major depressive cycles too. This gets very confusing, and it can seem sort of contradictory when you're analyzing this concept. But that goes to say that the major depressive disorder has certain specifiers, and some of those specifiers can include an individual having cycles of slight mania and slight hypomania as well. Another enhancement is this restructuring of substance use disorders for consistency and clarity. And this is where the DSM-5 attempts to define certain terms so that these terms are not confused by the general public. For example, the idea of this notion of having a drug dependence and sort of juxtaposing that concept with having an addiction. So a lot of people will confuse the term dependence with the term addiction. And so the DSM-5 actually goes to explain that these terms are different. For example, someone that has an anxiety disorder could be dependent on taking benzodiazepines or taking anxiolytic psychotropic medications to reduce that anxiety, but that doesn't necessarily mean that they are addicted. They're just dependent on the drug to not experience symptoms of anxiety. Whereas addiction is much more profound. This includes having a predilection towards a substance such as cocaine and not being able to control one's affinity towards that substance. So the terms are very different, and so the DSM-5 has done a great job to kind of define what certain terms that are widely misconstrued by the general population mean. And the sixth enhancement that has been made is this enhanced specificity for major and mild neurocognitive disorders. And this is very important because in the past, you would see that medical professionals would even psychologists and psychiatrists would somewhat confuse Huntington's disease, symptoms of Huntington's with Alzheimer's disease and dementia and multiple sclerosis. When you're dealing with mental illnesses that deal with the breaking down of cells in the brain and the neurodegeneration of cells, it's very easy to misdiagnose clients that could be experiencing those particular illnesses. So the DSM-5 really differentiates from Huntington's to Alzheimer's and dementia and multiple sclerosis, along with other illnesses that involved neurodegeneration. And then finally, you have this transition into conceptualizing personality disorders using what's known as a more dimensional approach, contrary to this categorical / multi-axial system that was previously used in the DSM-4. So those are some of the enhancements that the DSM-5 has incorporated. That being said, I'm going to go ahead and sort of explain what the first classification of mental health disorders is in the DSM-5, and that is neurodevelopmental disorders. So the DSM-5 starts off by talking about neurodevelopmental disorders, which makes sense because these are sort of the umbrella of mental illnesses. Usually, when a child is exhibiting issues, growing up, it's always safe to say that there could be a neurodevelopmental disorder that is at hand. So the DSM-5 starts by talking about these types of illnesses. The way that neurodevelopmental disorders are defined is that these are deficits in personality, deficits in social, academic, and deficits in occupational functioning. And under the umbrella of neurodevelopmental disorders, you do have, of course, you do have autism spectrum disorder. And there's this idea that neurodevelopmental disorders have the tendency to co-occur with other disorders. For example, what you see with autism spectrum disorder is this co-occurrence with intellectual disabilities. And then you have the same phenomena taking place with ADHD, where you have a co-occurrence with other learning disorders. And then, when clients have these issues, especially children, you do see deficits and delays in reaching expected milestones. And so that's really how you define a neurodevelopmental disability. More specifically, under the umbrella of these types of disorders, you do have intellectual disability, and this would be a deficit in general mental ability. So this includes issues with reasoning, issues with problem solving, difficulties planning, having a hard time engaging in what's known as abstract thinking or philosophical thinking, demonstrating judgment impairments, academic learning issues, and even learning from past experiences in one's life. Can be difficult when the person has an intellectual disability. And these deficits result in a failure to meet the standards of personal independence. For example, independent living, social participation, and even occupational functioning can be impaired when the individual has an intellectual disability. It's important to add that intellectual disabilities are not just limited to these functional domains that I talked about. You also have communication disorders that can be caused by having an intellectual impairment. So these include having language disorder, having a speech and sound disorders, along with stuttering and things of that nature. Those can also be indicative of an intellectual disability. So let's talk about the intellectual disability, because there's a specific symptom criteria that an individual has to meet in order to be diagnosed with the intellectual disability. And I'm actually going to pull out my copy of the DSM-5 so that I can read what that symptom criterion is. So the first thing that's important to note is that there has to be deficits in conceptual, social, and practical domains. And I'm going to talk about what those three domains entail in just a little bit here. But all of the criteria for the intellectual disability must be met in order for a mental health clinician to diagnose an individual with that disorder. So let me go ahead and read the DSM-5 criteria for intellectual disability. And so criteria A, you have what's known as deficits in intellectual functioning. such as reasoning, problem solving, planning, abstract thinking, judgment. As I kind of mentioned before, I think I did mention these points before. Academic learning and then learning from experience. So those are the generalized criteria A. Criteria B, you have deficits in adaptive functioning that result in a failure to meet developmental and social cultural standards for personal independence and social responsibility. And then the last criteria, you have that the onset of the intellectual and adaptive deficits must have occurred during the developmental onset period. So those are the symptom criteria. Um, all three of them must be met. I do have to comment on the last criteria that was listed there. So the onset of the intellectual disability and the adaptive deficits must have occurred during the developmental period, and the way that the DSM-5 defines this developmental period is that the disorder would have occurred before the age of 18. That's how they are defining a developmental period. It must occur before the age of 18. Going back to what was mentioned before I listed those criteria, I did talk about this idea of having a conceptual, social, and practical domain. I'm going to get into that here real quick. I do want to mention that there are severity specifiers to the intellectual disability. So you have mild, you have moderate, you have severe, and then you have profound. Um, and these levels of functioning, these specifiers rather, are not based on IQ. That's important to note there, that these are not based on IQ. They're rather based on adaptive functioning. And so this really takes us into the different domains there. So let's start with the conceptual domain. So the conceptual domain represents very little understanding of written language, and a poor understanding of concepts that could be abstract or that could be simple, such as numbers, quantitative measurements, and such forth. So that is the conceptual domain. And you'll see that children who exemplify issues in this particular domain have a hard time in academic lessons such as writing, reading, language comprehension, and such forth. The social domain involves a limited vocabulary and a poor grammar. And this could make it very difficult to engage in social interactions, understanding social reciprocity, and even communicating with others in social settings. And then the practical domain, this is where the individual needs support or that they require support in activities of daily living, such as preparing meals, dressing themselves, bathing, and even elimination and such forth. So those are the sort of the general requirements for an individual to meet a diagnosis of intellectual disability. The prevalence of this disorder is about 1% in the general population. So this means that 6 out of every 1,000 person that you will encounter will have an intellectual disability. So that wraps up this first section of the DSM analysis. I will pick it up in the next section by talking about language disorders, and we're going to get into the symptom criteria for language disorders, and then we will also talk about autism, furthermore talk about autism and other mental health disorders in the next video. Thank you so much for watching, and I will see you guys next time.